level some years ago. I've been a hygienist for, yikes, 30 years this year. I was a hygienist 7 years, or a dental assistant 7 years prior. I had a little overlap there of 1 year, so I have a 36 total years. Owned a couple of my own dental practices, because here in Arizona we can do that. So much like some of you are going about to be, be a business owner. It's not the easiest thing. So I do feel for you. It's hard to be stuck in someone's mouth all day, run a business, market, do all the things you have to do. So I applaud you. And I know if I can do it, though, those that are you are going to buy will be totally fine. So don't fear. I have spoke for Invisalign and BioLace for many years. And the only reason I bring that up is just literally I'm super passionate about clear aligners or putting teeth in the right place, however you do it. Super passionate about laser hygiene. So when I help hygiene teams, I help implement all of this stuff, which helps them be, boost their production, be more profitable for the practice. However, tonight we're going to focus on a lot of the basics. This is just a disclaimer. I'm not even going to read it. I just put it there because they are my own opinions and things. And I really, am open to sharing pretty much anything. So I don't have any live patients or anything on here. So you can take away pictures, all you want to do. Okay. So tonight, I'm just going to do brass tacks rather than read off the 5 things, is how to boost your hygiene department. And I think it's so much deeper than just what tools we can add to the toolbox. I didn't even really focus on that because dealing with hygiene teams every day, being one myself, I find that even some of the basic things aren't being done. So before we go add lasers, clear aligners, different things that the hygienists can do to help reduce production in those ways, it's really just getting them to do some of the basic things that are required of a hygienist. I just take that down. So I think one of the biggest shifts happening in dentistry right now is the evolution of the hygiene department. It really has changed over the years, and I'm so happy to be part of that journey. If I would have stayed where I was 30 years ago, it wouldn't be so cool. But there's so much evolution going on, so much opportunity. I think, modern dentistry is a really cool place to be these days. It's where we get the most one-on-one time with our patients. We get to diagnose, influence, help you with patient retention, help you with enrollment, not only what I'm enrolling, but what you're enrolling, whether it be crowns, again, clear aligners, anything. We are really there to help co-discover, co-diagnose with you and the patient. So we have so much influence. There's really no other healthcare provider out there that gets 1 hour every 6 months, one-on-one with their patient. So it's nice if we can figure out how do we use that time. Scaling teeth is super important. I don't want you guys to think it's not, but there's so many other things that go into the appointment that if we can get, and again, those hygienists to get there, that would be super great. It's not really just selling more. I would say, we think about all the things that I just talked about, all the tools in your toolbox, and it's not really just about selling more. It's really, for me, about diagnosis, diagnosing what we see, not doing too much in an appointment that may be a prophy, shouldn't be a prophy, things like that. So it's really all of that, just making sure that we're diagnosing properly, which is going to be what I'm talking about first. One thing I see constantly when I'm consulting. Yes, did someone say my name?
No.
Okay. Yes.
No, but does anybody have any questions so far? Since we're taking a minute?
I'll take a breath after I go through these next couple slides, and we'll kind of chit chat about them because I do have a couple of questions. Anybody questions yet, though?
No.
Okay, awesome. So one thing that I see constantly when I'm consulting is the inconsistency in diagnosis from provider to provider. And right now I'm talking about hygiene. Um, when you have two people, and you guys have probably seen this, and even your career as being associates, being owners, being in dental school, two people can look at the exact same patient and come to two very different conclusions. And it becomes very confusing for a patient. I joke a lot and I say, like, it's like when I go in to get my car fixed and they give me 3 or 4 things when I come out, and I'm looking at them like, yeah, I totally get it. I totally need to do that. And then by the time I leave, if somebody asks me, well, what did they say is wrong? I'm like, I have no idea. I just, I said, yes, it sounded good. And then I'm like, wait, do I actually need it? I don't know. I don't even know if my car's not making noises. Do I really need that filter changed? Whatever. So, patients really feel like that, or even worse, when they come out of our chair sometimes. So we just want to really make sure that we're taking the time and explaining to them, and that your team, you're collaborated, you're on the same page. One of the things that's really missed is like early inflammation, recession, broken restorations, even perio. After a while, it gets very normalized to us, but it's not to a patient. So when we start talking to each other and we're identifying all the stuff that they need, and we're talking very clinical to them, I think that a lot of the diagnosis becomes like missed in that conversation. Have you ever felt like that when you're talking to a patient, that you're saying all these things and they're kind of shaking their head yes, but maybe they're not getting it? Or even worse, they leave and don't schedule? That's a yes. Okay.
Yes.
So really, when patients move forward, we talk about this all the time when I'm consulting, and we've got a group of patients that will just say yes to anything because you're the doctor. You tell them to do it. They don't know. They just do it. You have a group that won't do anything no matter what you say. They're the emergency patients that you're thinking, I told you so, like even last week. And then you have that percent, that 25%, it's kind of a little bit different in every practice, that is only going to move forward when they completely understand what's behind the treatment, the why. When you talk in their language, that's when they're really going to move forward. And in every practice we look at, those are the ones that don't move, and then the doctor's left with wanting more patients. I need more new patients. I need more new patients, rather than concentrating on the ones that have been in their practice, are loyal to them, maybe not moving forward, and there's something else holding them back, just besides, hey, we told them to do this. So the confidence that you have when you present, the communication that you provide, the collaboration that you have with each other, these are all the things that are going to matter. And diagnosing consistency matters. This has happened to me so many times, doctors, and if you don't own, or you have owned, you can probably ask for feedback, where I'll like tee it up, like it'll be sitting there on the top of the, whatever the golf tee, or the baseball thing, whatever it is, literally sitting there, and I'll say something and the doctor will be like, oh, we can watch that. Or worse, they don't even look at it. They get preoccupied with like something baseball, and they walk out, and it just never gets addressed. And what that does for a patient, it's not really like, for them, they just think, oh, it wasn't important. Like, why wasn't that said? The hygienist just spent 15 minutes talking to me about it. Doctor says nothing. So it's either now we don't trust the doctor, or was the hygienist lying to us? So all these little things matter in a practice. So that's what I would like to challenge you with. If the patients rotated through all the providers in your practice, and if there's only you and the hygienist, that would be it. If there's multiple associates or things, or multiple hygienists, would you diagnose and recommend your recommendations be consistent? Like, would it be the same thing, or would it be different? And if it's even questionable, it's kind of like, now it's time to collaborate. It's time for you guys to sit down and like look at this. Any thoughts or questions on what I'm saying there? Hopefully that makes sense. Just that diagnostic consistency.
I'll say this, Paula, you can hear me? Yes.
Mhm.
We use dental intelligence a lot, and in dental intel, I don't know if you guys know this, if any of you that have had it, you can see the doctor's closing percentage with every other provider in the office. And we actually track some of this, and it's interesting how some hygienists you all are rock stars with, and some you're abysmal with. And then the question is why? And it's bridging that gap, which is essentially what Paula's basically getting at. So maybe you're getting that, Paula, but how can these guys maybe track this without dental intel, or is there a way to diagnose the problem that you're discussing right now?
Yeah, I mean, I'm going to get to KPIs and kind of how to see that at the end, but I do think that, like, if you have software, I mean, doing it by the month is kind of doing it injustice. If you're going to measure anything, I would definitely do it by the week, if not the day. And that is one beautiful thing about dental intel is you have the luxury of doing it by day. If you have to go old fashioned and look at the amount of treatment that was presented versus accepted, it's a little bit harder in each one of the softwares. But I'm focusing on hygiene. What I find, I guess the reason I'm hitting on that, I'll back up 1 second. The other reason I'm hitting on this is far too often, and I'm going to get to this in a minute, hygienists will see bleeding gums. They will do all kinds of things, and they'll do a prophy. We call them Prophy Queens, bloody prophies, all kinds of things. And that's kind of where my whole presentation is getting to, is diagnosing correct the first time. Because two things, and this, thank goodness there are no hygienists in the room tonight besides me. But unless Christy, are you one? Were you one?
Oh, I didn't know, never.
No. Someone asked if they could bring. Who was that?
No, I know. I didn't want to beat them up tonight. This was all positive stuff, but what I see way too often is, and I'm about to get to gingivitis, is we're taking away from the financials and the practice. So when we talk about, the whole night is about boosting your hygiene production. And the number one thing is just getting your hygienist to diagnose properly and consistently. So if we're doing bloody prophies, and that could have been a periodontal therapy, we've now taken away multiple appointments, reimbursement rates, all kinds of things that should have happened instead of us doing a bloody prophy. So really getting your diagnostic consistency and collaboration against the team and calibrated with each hygienist is really important. So coming up with, what does that perio program look like? Does that make more sense than kind of where I was going before?
Yeah.
Okay.
What are your feelings on AI for that consistency?
Love it. I'm my next, thing is an old fashioned perio charting. And one of the things that I find most about this is that we are not doing, if we're going in and we're spot probing, or we're going in, which I see 90% of the time, we're doing numbers and no bleeding and no mobility and no recession. We're missing the mark every time. So I think, was that you, Chrissy, that asked that?
Yeah.
Yeah, 100%, hands down. Even doctors, like, I love, there's actually a one out there that's a little bit cheaper than Overjet and Pearl, and I want to say it's Denta AI. You kind of have to look at all the different investments because they're going to come out of the woodwork now, and I'm shocked that Dentrix, Eaglesoft, and Open Dental don't already have them because they're going to buy one of these companies up for sure. But what's that?
Vidya Health, I think is what it's called.
Say it again.
Vidya Health is the Dentrix system.
Oh, okay. Yeah, because it's, if we're not going to do it, because whether we're cutting corners, whether we don't feel it's necessary, whether time doesn't allow, whatever it is, we're doing both the patient and the practice a disservice, because The minute I don't do a full perio charting, I'm missing bleeding, I'm missing depths, and now I'm going to what? A prophy. And the minute I do that, I've now misdiagnosed the patient. I've now taken money from the practice, and this patient goes off into the sunset for the next 6 months. So we've now normalized inflammation and bleeding. We've made it okay. Not a big deal. We still tell the patients they're doing an excellent job. You're just bleeding a little. I know all you dentists out there say little cavity, little this, little that. In my practice, that was a curse word, and you put money in the jar. And we went to lunch on all the times that you said little or kind of, or, you know, whatever it was. But it is a serious thing that I was joking there. That was a joke. Although we do it, I do it, we all do it, because we want the patient to feel good. We don't want the patient to feel shamed. We're trying to kind of boost confidence and earn that trust. So instead of earning it in other ways, we minimize things that are happening in their mouth. And so I love AI. And if we don't have AI, we need to do a full perio charting. There's so many other avenues out there. We can use a speaker, we can grab a dental assistant. And I'm going to get to that in a minute, that really if the hygiene team is not treated like the blood, the heart of the practice, it's a shame and it's a miss. And I've seen it too often. I've been in practices where I need a perio charting. I'm the highest paid person in the practice. Nobody's going to help me. She can do it herself. I've got stuff to do. And we're going to kind of talk about that when we start talking about what a hygienist should be producing. But disease is a very big missed opportunity. Do not let it, and I actually should have done this for you tonight. Prophy's reimbursement from insurance is, let's call it, I mean, you guys probably know better than me. Throw out a few numbers. Just a prophy. Docs?
170.
Yeah. Yeah, you're looking probably anywhere from 60s to 85, depending on the area you're in. That's a prophy. And that prophy is done every 6 months. When someone turns it, now listen, I'm not making someone turn into perio. They have perio. This is a true diagnosis. Now we're talking what a quad. Limited, we're in the 100 somethings. Full, we're in the 200 something. Some areas even 300. We have 4 quads. Now that patient goes into perio maintenance. We're seeing them every 3 months. What a missed opportunity for us. Not to mention just the health of the actual patient themselves. We've let that person, again, run off into the sunset with a disease because we were in a hurry and didn't do a full perio charting. Does that make sense? Does anyone have an argument? And when I say full perio charting, if we've already done one, we don't have to start from scratch. We can use the same one. We still just need to probe every area.
Questions?
So with a new patient, how long is the appointment? Like ideal appointment? To say like 60 minutes or 90 minutes?
Great question.
Yeah, great question. And this is probably like one of the hardest things I work through with an office. A true new patient appointment should be 90 minutes. Now, depending on the age and depending on when they were seen last, you may find that's way too much time. The problem is our front office aren't the best at fielding those conversations, and we can't see in a patient's mouth, and we don't have their records when we're scheduling an appointment. So gut is always 90 minutes. Now, whether that first 30 minutes is on doctor side and the next 60 minutes are on hygiene side, or full 90 minutes in the hygiene side. I love when we can do 90 minutes on hygiene side. The two problems as a business owner, which I've been one, is if they don't show up, I just wasted 90 minutes instead of 60. And the second is I just took 90 minutes just, you know, out of the hygiene chair, and I can't fit another patient in there. So ideally we would want 90 minutes on the hygiene chair so that they can do the full, you know, patient experience and get the relationship with them. But financially, it really works better if 30 minutes are in the dentist chair and then 60 minutes in hygiene. That way, if they cancel or just filling the hygiene schedule with more productive stuff, that we can allow just a 60-minute appointment. That means the dentist has to stay on time. The other great thing is the x-rays are taken, you know, so usually so it depends on your mindset. Perfect world would be 90 minutes in my chair. I'm doing everything from beginning to end. We've got complete enrollment and I'm a rock star. The next best thing is 30 minutes in doctor's chair because we want financially not, you know, for the patient not to cancel. And obviously a full mouth x-ray is all the extra money that I'm producing in that 30 minutes. So you just have to be on time because you're going to get it clobbered by your hygienist. If you don't get to that patient, you get the x-rays, get the exam done, because now they're going to end up in my chair and I'm going to have to do all that. I think worst case scenario is the x-rays at least get, or best case scenario is the x-rays at least get taken, because if you take a full mouth for me and I still have a full hour, I'm okay. That's okay. Even if you have to come in and still do the exam. But typically on those first comprehensive exams, you guys like to spend how many minutes?
On the patient, at least 20-ish, 30 minutes.
Yeah. So if you give me an hour and all you got was x-rays, now you put them in my chair and you come in and do your 20 to 30 minute exam. And now I'm back down to 30, maybe 40 minutes max. Makes sense? So it's, you know, it's always that, you know, how quick are you in? How quick are you to do an exam? It's never perfect. It's unfortunate. It's never perfect. So I don't have a perfect answer for you. I think as a business owner, I would want 30 minutes in the doctor or the assistant chair, and I would want an hour in my hygiene chair, just for a financial aspect of it. If you're more boutique-y and you want to create more personal relationships, probably gonna be better off putting me 90 minutes in the actual hygiene chair. Does that answer your question?
Yes.
Okay. So if disease is being missed, treatment opportunities being missed. So again, this isn't about finding dentistry, but it's about identifying and treating conditions early, which organically leads to more dentistry. Does that make sense? Okay, the next thing, we're not gonna get into perio. It's gonna feel like it for a minute, but I'm gonna be really brief on these, and you all might have a lot of questions, but I don't want to get into the gingivitis code unless that's where you want to take it. But I think one of the biggest missed opportunities in hygiene is underdiagnosing gingivitis. Really, there should be about 20% diagnosing of gingivitis in your practice. It's a code that came out 2017, 2018. And it bridges the gap between, you know, prophy and early intervention of periodontal disease. And so if you're not utilizing this code, this gets you 2 appointments. It gets you about 1.5 times a prophy for the first appointment. And they come back 4 to 6 weeks for a prophy for the next visit. Again, as you're watching this, you're going to see the hygiene chair is going to fill up quickly. Not only is it going to fill up and you're going to need another hygiene day, but it's going to fill up with more productive stuff than a prophy. So this is another way you're going to boost your hygiene production, is you're going to diagnose properly. You're going to perio chart so that you can diagnose properly. And then you're going to utilize other codes besides prophy, perio, like gingivitis therapy. Okay. Any questions?
Does everybody know that is familiar with this code?
Oh, they probably don't. And I don't open that.
Dr. Chong does not. I think he was one of our clients once, so I'm embarrassed.
Don't be embarrassed. So how many patients, I want them to raise their hand, and I'm not going to be able to see it, Michael, so you tell me. How many patients do you think leave your hygiene chair every day with inflammation, but that might be documented, but never truly diagnosed with this code?
So many. 50% of patients for sure.
How many?
At least 50% of the prophies.
Yeah.
50% of the prophies, she said, to be honest.
Correct. So it's a missed, and again, we as hygienists all learn this. It's that diagnostic inconsistency. It's not charting. It's not feeling like you have enough time. These are easy fixes, time management, and I'm going to get into that in just a minute as well. Do you want me to explain the gingivitis therapy?
Yes, I think they do.
Okay, I'll go back to this slide just because there is.
Good thing. Yeah, you didn't want to, but we're making you do it.
No, it's not that I didn't want to. I just didn't want to. I didn't want to take it down a rabbit hole if they weren't interested. So no, I totally am fine doing it. Are you kidding? I love gingivitis. I love hygiene. I love this stuff. So basically this is gingival disease. It's inflammation. So it is reversible. So this is when the bacteria penetrates in the gum and surrounding tissues, but not the bone. So this isn't like a full mouth debridement where we're like, oh, let's do a full mouth debridement, bring you back and reassess and see if you're periodontal disease or not. Hygienists love to do that. It cracks me up. I know you have periodontal disease or you don't. Now, it doesn't mean you can't do a 4355, which is a full mouth debridement, but I don't need to bring you back to assess you. I already know you have periodontal disease. It's not going to get better. You have bone loss. But they love to do that because that's their warming up of diagnosing somebody with periodontal disease. This is, you have no signs of bone loss. This is a patient with true gingivitis. This can be done on any age. There's no age limit. There's no contraindications. This is somebody that could be 5, they could be 12 with braces, they can be 40, but they have no signs of bone loss. So this is a 2 and done. I'm going to clean you. It's going to feel like a full mouth debridement because what I'm going to do is do a 2-part cleaning. I'm going to get, if there's tartar, a lot of it's biofilm because remember, it isn't a full mouth debridement, it's gingivitis. So there may or may not be a lot of tartar on here, but there's a lot of inflammation. It doesn't have to look like this person. It's 30% of the mouth or more. I have it on my other side and I didn't bring it, but I can do it really fast because it is a very fun statistic. So if we have 32, well, we usually have 28 teeth, right? I mean, and we've got 6 surfaces and then 0.30. So 50 of the 168 points of perio charting need to be bleeding. Okay, real close to it. If they look like this and they don't bleed, or they're a smoker and they don't bleed, I'd probably be helping them along a little bit. But if we truly know they have gingivitis, it's 30% of the mouth or more is bleeding when I probe. Okay, it's induced. It's from plaque. Sometimes it's from medications. It can be from, like I said, Invisalign, brackets and wires. It can be from anything, but I'm inflamed and 30% of my mouth or more is bleeding. I need a 2-part cleaning. So basically I say to the patient, it's also those patients where I find that haven't been in 2 years. So usually I say to the patient, hey, you've missed, 4 professional cleanings, 6 professional cleanings. What I'm seeing now, the good news is, it's reversible. The bad news is it's gingivitis. We need to get in and clean that up, or the next stage is periodontal disease. It's a 2-part visit, and we can get you taken care of today and bring you back in 4 to 6 weeks. So it's basically just inflammation. At this appointment, I'm going to do high-level Cavitron, some scaling. I'm going to bring them back in 4 to 6 weeks and do an actual prophy. And I'm going to charge out both of them. 43, 46 first visit, prophy second visit. This can be graded. The tricky thing about this is your insurance verification has to be really good because it can stand alone as its own code and be covered at 100%. It can take the place of a prophy, and it can also be thrown into a perio category where it's subject to the deductible and it's covered at 80%. So insurance verification is super important. I love to tell my teams, all new patients, find everything out you can about this code. Do not leave anything uncovered about this code I assume every new patient is going to have gum disease. Do they have gingivitis? Do they have full mouth debridement potential, or are they perio? I don't know yet, but I want to be prepared as a hygienist and as a front office treatment plan coordinator. We're like ready to present this so that I can do it same day. I can do a quad of therapy, I can do this, or I can do full mouth debridement without sitting and waiting 20 minutes on my front office to figure this out. If I'm a really sharp hygienist, I can talk about this. I don't even need my front office. We've got it broken down already. Hey, you haven't met your deductible. Here's what I'm seeing, blah, blah, blah. You owe $70 today. It's that easy. If I'm not prepared, I'm like a deer in the headlights. I'm going to go ahead and do a prophy because my time is ticking, and I'm not going to go get Olivia or Ginger up front because she's going to take 20 minutes of my appointment and I'm going to get nothing done. Okay. So being prepared for this is super important. What questions do you have on all of that? It was a lot.
So I was told that in the debridement, you could do an exam the same day. Is that the same for this code?
This is not a debridement. This is a gingivitis therapy, but back 2 years ago, they changed it where you can do a comprehensive exam and a debridement in the same day. It's about your clinical notes. You just want them in order. You went in, saw them, diagnosed a full amount of debridement, came back and did the comprehensive exam. So you can now do that. I think that happened 2 years ago, 2024. This has never had that rule. This is totally different because the reason the full amount of debridement was like that is because they were saying there's so much tartar, I can't see. So I have to do this procedure. How can you tell me, all of this stuff and do a comprehensive exam if you can't see because there's so much tartar? So they made that rule, but they changed that now. And then this doesn't even need tartar. This is just, it can have tartar, but this is more about inflammation.
And all insurance companies kind of look at this the same or totally different, or?
No, I said that. So some will categorize this on a code of its own, covered at 100%. Some will downgrade to a prophy, and some will count it as a perio code. You'll be subject to deductible unless you've met it, and it'll be covered at 80%. You have to remember, though, even if they downgrade it, what you're doing here is you're setting the tone for your patient, because now you're going to wipe out 2 of their prophies. You're going to do a prophy. You're going to do a gingivitis therapy, downgraded to a prophy. 4 to 6 weeks, you're going to use up their other prophy. It's all about education and them understanding. The minute I just do a prophy, or I'm like, oh, they're going to downgrade it to a prophy, I can't just bring them back in 4 to 6 weeks and do another prophy now because I didn't educate them on what was happening. It's not my responsibility. It's my responsibility as an office to educate them on their insurance, but it's not my responsibility to diagnose because their insurance is going to downgrade it. That's not my problem. They have gingivitis. They need a 2-part appointment. And if left untreated, this turns into periodontal disease. That's all I care about as a clinician.
Any questions about that? Because as an outsider of clinical and hearing front office all the time, offices just do based on insurance. And I would say that's a vast majority. And it really is on you as the leaders to do a policy and educate, communicate, and not do it based on what they're saying, but do on what you're seeing.
Or just feeding into the patient who thinks that the only dental need they have is what their insurance covers.
That's right.
So we feed that.
We feed it. We feed the problem. It's like going to a medical doctor.
Yeah.
That would be like me saying you have diabetes, but it's not covered, so we're not going to treat it. And instead we're going to just give you a cholesterol. I mean, I don't know, some placebo pill. I don't know. I'm trying to think of something that would match and mirror that, but you know what I mean? It's like the reason I truly believe patients only want what insurance covers is because they don't understand the impact on their health.
Right.
They don't understand the consequence of leaving this untreated. What I'm doing, if I just do a prophy on this, guess what? They're going to come back in 6 months and probably look worse or the same. Now, what I've done is I've left biofilm, bacteria. They probably have now lost a millimeter of bone in some places. Then I do it again and I do it again. I literally did not put my patient's health in their own hands. I made a decision because I felt bad because their insurance didn't cover it. And I ran out of time, or worse, I'm not educated enough to actually explain it, is the way I look at it. Does that make sense? Does that offend anyone? And I'm happy to talk it through. It'd be like me needing a crown and you're like, well, the copay's more, so I'll just put a 5 surface filling in there for now and wait until their major kicks in. Now, maybe 1 week before, but you're not going to do that, right? You're going to say, hey, this tooth is going to break. Here are all the risks. We've got to do it. It's not going to make it if we don't. Or like you do a root canal and my crown benefits aren't going to be there for a year. And you're like, maybe you would do a core buildup. Like, I don't know, but most people aren't going to. They're going to say, if we don't protect this tooth, it's going to break. And now I'm going to actually have to pull that root canal tooth that you just spent X amount of dollars on because we didn't finish the treatment. Is it clicking? Am I doing?
They're all shaking their heads.
Okay, I can't see you, so
You did good.
okay. Well, let me know if I need to work through something with someone, because again, you can't be a clinician for 36 years and not care about patient first. So I want you to know that everything I'm saying comes from love and true diagnosis, nothing made up. Just know that about me. The other thing is, you know, I get in practices all the time. Again, Michael talked about dental intel in the beginning, and I'm going to say it right here again. Most of my practices are anywhere between 5% perio and 19% perio. Okay. And this practice has been established for a long time. So we're even counting perio maintenances. We're not just counting fresh perio. We're counting like the history of the practice. We're still at 5, 9, 15%. If nearly half of the adult population in the United States over the age of 30 has periodontal disease, all the practices cannot be healthy, because that's what I hear, where our practice is healthy. Listen, I live in Scottsdale, Arizona. There's probably not more people that care about their teeth and their beauty and their blah, blah, blah than right here where I live. And my neighbor has periodontal disease. I can smell it. So it has nothing to do with where you live. We sure, if you go, we're talking the depths of poverty versus people with money. Absolutely. You're going to compare the two, and there's going to be more people, but there are rich people who have periodontal disease and who ignore it. So it's hard to believe when I get into a practice that if half the United States over the age 30 has periodontal disease, that we have 5% perio in our practice. So what I'm saying about all of this is disease is prevalent, and if it's truly this high, practices are probably very underdiagnosing periodontal disease. Yes or no?
So it's about the conversation. That's all.
Did I hear yes? I didn't get a yes.
Yeah, they all said yes.
Okay.
So it's about the conversation because
100%.
it's there.
It's there. I see it. And listen, I already knew it as a hygienist, but now that I'm coaching my last, 10 years? I don't know. I'd have to like think back. I'm being more, so when I was a hygienist, I only knew the people that worked with me. And if I came into a new office, obviously I would see it behind me. When I own my practice, I had giant hygienists that worked for me. But it's coaching that really opened my eyes to when I'm seeing this 5%, 9%, 12% perio, I'm thinking, wow, people actually aren't diagnosing what's happening. And then I go in practices and I pull open a perio charting and it's some measurements, or it hasn't been done in 2 years or 3 years. That would be like not taking x-rays on your patients to see if there's, cavities in between the teeth. That's an injustice to the patient, I feel. Anyway, so like Michael said, it really is better communication leads to earlier intervention, leads to healthier patients. So when patients are declining, sometimes it's because we're failing them to understand the problem clear enough, or we're not calibrated, we're not collaborated, we're not consistent. Patients only trust when it all is connecting, and when it's not connecting, we're not doing it. Sometimes we're doing it, sometimes we're not. So let's go back to that again. In order to boost your hygiene production, we need diagnostic consistency, whether you want to talk about the collaboration of it, the consistency of doing it, or what I call calling a spade, truly diagnosing what I see. The only way we can do that is through a full perio charting, understanding coding, and truly calling that spade a spade.
And the front office being prepared too, right?
Oh yeah, 100%. That's the majority of it. I'm gonna bounce around, and now I'm gonna go into periodontal maintenance. And the reason I'm gonna go into periodontal maintenance is because we're talking about perio, and what I see more than anything is these turning back into prophies. These going 4 months, 5 months, 6 months. There's a lot of literature out there that a majority, I'm talking full comprehensive periotherapy, not one quad. Once you're in the perio, we are now in a maintenance phase. When we see a patient look amazing, it's because they've been being seen every 3 months. It's because they're getting the care that they need. The minute we start stretching that out, and I won't get into biofilm and all the P. gingivitis and, timelines, I'm just going to say one thing about it. Evidence shows that about 89 days, right before that 90-day mark, 85 to 89 days, that is when the bacteria that causes periodontal disease starts to rear its ugly head again. This is why the 3-month came about. So if we're starting to push that patient out for 6 months, not only are we doing them disservice because they're probably going to get active periodontal disease again, we've lost out on some perio maintenances. Like, let's keep the patient healthy. Let's keep them in a maintenance phase. And it's a win-win for the patient and the practice. Even if a patient stays on a perio maintenance every 3 months, I can almost promise you at that 2 to 4 year mark, they need periotherapy again. That's a whole nother lecture of why a patient is a periotherapy one and done. SRP if I'm losing anybody on the periotherapy. Really, it's insurance pays every 2 years for a reason. They know that a patient isn't one and done on SRP's periotherapy. Insurance, can we all agree insurance doesn't pay for a lot, correct?
Right.
Okay. Crown replacements every 5 to 7 years, fillings every couple years. I always look at it, if insurance is willing to pay, they know it's going to fail at some point. So I'm not saying automatically do periotherapy every 2 years. I'm saying for a patient to go through your practice of a lifetime and only get a one and done and they're on perio maintenance for the rest of their life, or they got moved back to a prophy and never relapse, means somebody is underdiagnosing in the practice. And I can feel pretty confident in saying that. Now, I'm not talking the 1 in 10,000. Sure, there's always an exception to the rule, but for the most part, that's happening. Okay. Any feedback on that? Any disagreements? Any more conversation we need about that? Okay. Another way that you can boost your production and we've kind of been going through this after diagnosing correctly, is building that trust. So cost is absolutely a factor in dentistry when we're making a decision to move forward, but it's rarely the only factor. Many patients delay treatments because they don't fully understand, which we started the conversation with. They don't fully understand the condition, the consequence of waiting, the value of moving forward. So it's not, you could be someone who moves toward pain or away from pain. So it's not all about the consequences of waiting. For me, it might be the value of moving forward. So you have to think about those things when you're talking to patients. Does that register? So in many practices, improving communication and patient education alone, just that alone, significantly improves your treatment enrollment. You don't have to do anything crazy. I love the big screens. I love the intraoral cameras all day long, 100%. A picture's worth 1,000 words. But sometimes if you don't have that, you can't invest in it right now. Sometimes, most of the time, just improving that communication is going to be what improves your treatment enrollment without changing fees, financing options, anything else. So I think we sometimes assume patients are saying no because finances, really they're just not understanding what we're putting down. So this right here, improving the communication, is going to be one thing that really helps when you can't invest in all the other stuff. So I'm going to move through this quickly because I know we've been doing this for a while. Finding out what matters most to the patient. This is how we understand and talk to them. Is it comfort and pain, aesthetics? What do they value most besides just the tooth that hurts in their mouth? I talk to them in this way. I talk in a good news, bad news. So I will say, I kind of did it with the gingivitis a minute ago, is when I understand that what you value most is comfort or pain, then I'm going to talk about the good news and bad news. Is the good news is we can keep you out of pain. We can do your treatment here, and we can do it in just a few appointments. The bad news is you have periodontal disease. It's going to take a few visits, has penetrated in the bone and the surrounding structures. And if left untreated, which goes in the problem consequence solution, which is more what doctors talk in, if left untreated, this is going to lead to tooth loss. So I couple what matters most to the patient, the good news, bad news, which is kind of the problem consequence solution, just a little bit different spin on it, all together to help talk in the patient's language and help them understand what's important. Okay.
There are courses on those 3 slides.
Yes. All of this is one big course. So sorry if it's too much. I'm gonna skip on to time management really quickly because I think it's really important. It helps maximize that chair. I say this with love, and I would not walk in and say this to your hygienist on Monday morning. He or she will never speak to you again. If you are taking longer than 20 minutes, the scale and Cavitron, it's probably not a Prophy. If it is a Prophy, they need to be seen more frequently than every 6 months, whether their insurance covers or not. Because I am not going to rob my dentist by spending an hour running behind, scaling a patient that doesn't take good care of their teeth. A true Prophy is 20 minutes. So 2 things. If it takes me longer than 20 minutes to scale and Cavitron, not polish and all the other stuff, that means it's probably not a Prophy. If I can argue it is a Prophy, then that person needs to be on a more frequent recare because maybe they're drinking too much wine like you guys. And it's just all lower anterior tartar and stain. Okay. And there are those patients. So I'm not going to say that there aren't, but what I find in most of the time is we're just not diagnosing. Let's not intermit, and I'll go through handoffs really quickly as well. The power of a handoff, super huge. We want to do a couple things in a handoff. We want the patients to hear it more than a handoff is not for you to your hygienist or to your dental assistant or to your front office. A handoff is so the patient can understand more than once what's happening in this process. It builds trust and confidence in what you're saying, clear communication. So in that handoff, we want to make sure that we're passing the power. So one thing we want to do is if you all are the ones with the degree, I know I have one as well, but you are the ones with the bigger degree. Patients trust you. And even if they don't, even if it's me they trust, there's no harm in doing it. So when you pass the power, what you're doing is saying, Paul, if you could get Michael scheduled for his crown, okay? So you're passing the power to me to schedule Michael, and we're also creating urgency. So we're passing the power to your team member and creating urgency at the same time, okay? What patients hear if you don't do these things is watch it, eventually do it at your next cleaning, sometime or another. It's not that important. So you need to put timelines around it. Urgency does not mean emergency. It means a timeline. So it will be, Paula, I'd love for you to get Michael scheduled for that crown on the upper right in the next 1 to 2 weeks. So you gave me the power. It's you're the one wanting it done. And you gave me a timeline in which you would like that done. Now, no matter what happens next, I'm either scheduling him or I'm going to pass the power to another team member saying, doctor would like to see Michael for the upper right first in the next 1 to 2 weeks. You guys see what's happening there in that handoff? It's consistency, it's clear, and it's passing the power with an urgency around it. It's going to take you a million miles in your practice. Leverage your team. That was like a whole nother, Michael's giving me the white flag that we're out of time. So I'm not doing this on purpose. I do want to get to these last couple of things because I think these are other things that help boost profitability in your hygiene department, is maximizing the schedule. So all this creates better collaboration, better communication. What's most important about it is auditing the day. So what people do, and I'm going to kind of go back and forth between these two slides, is they mistake a morning huddle as an audit your day. I don't need to know what's on the doctor's schedule. I'm a hygienist. You all don't need to know what's on my schedule. You can see it. The code should be on there. That's a whole nother webinar study club if we're not putting codes on the schedule. If it's just an exam or if it's some words, call me because there's a problem. But what should be on there is what you're doing next. So individually, your dental assistants, your hygienist, your front office should all be auditing the schedule. We're looking for ways to reduce bottlenecking. We're looking for ways to increase opportunity. We're looking for unscheduled treatment and ways to reduce stress on the team and the patient. In the morning huddle, all we're going to talk about are those things. How do we prevent bottlenecking? What opportunities that we have on the schedule, and how do we reduce stress so that the patient has an amazing patient experience? New patients, of course, any information we have, I just don't want to leave that out because I know some of your heads are turning. Well, what about, yes, if there are things that are make or break an appointment. If it's something that you know that Paula, your patient hates, or Paula, your patient loves, we want to bring it up because we want that experience to be great. But we don't need to read the schedule ever. Why this will help boost your hygiene department is because we are looking at opportunities. I'm looking at opportunities as a hygienist. If I know the insurance verification breakdown is correct, can I do a night guard? Can I add sealants? Can I add fluoride? Can I scan for my doctor? Is there room in the doctor's chair that as soon as I'm done with this stuff, can they scan or take an impression for a night guard? Because I know they have a little break in their schedule or we have an extra assistant that day. So opportunity and looking at how do we prevent bottlenecks and create that opportunity and that crossover is what I want in the morning huddle. How do we make our patients' day better? How do we make our day better and more productive? That makes sense? Real quick, if you don't have templates, they should be stellar. The reason I put this in here is because one of the number one things I get is my hygienist stays 30 minutes after and does her notes. She runs 30 minutes into lunch. She runs 30 minutes after the day. If you're doing it as well, I would say, look at your templates, look at your documentation. How can you make that more robust so that it's less words that you have to fill in and more that's already there for you? Do I need to breathe for a second, Michael? Am I good?
You're good. You're good.
I just kind of want to get through these last few things. Sorry, it wasn't really deck heavy, but it's become it. Schedule to goal, pre-block. Pre-blocking isn't about being rigid, but it's about managing. As a hygienist, my favorite thing to do was manage my own schedule. I don't want the front office rescheduling because guess what? I don't want 3 FMXs in a row 6 months from now. I don't want 3 sets of bite wings in a row 6 months from now. What I want is bite wing, perio charting, bite wing, perio charting, or whatever it is. Even sometimes I'll throw no exam patient in there. I'll throw a 3-month perio maintenance. I get a design so that I am not like coming in and behind all day long. Yes, patients will cancel. Yes, the front office will run amok if they get an opportunity. We got to train them as well not to do this to me. But the more I design it, 80% of my day is going to go amazingly. And I'm going to have pre-blocks in for perio therapies, for opportunities, so that I can put a 90-minute comprehensive perio therapy in there, an SRP. So it's really just pre-blocking for new patients, for perio therapies. Somebody asked me earlier, 90 minutes for a new patient. The reason I also love that is because I can pre-block for both of those, and then they can be substituted for, if we don't get a perio, then we can put a new patient in there. Just throwing that in there. One of the biggest things of everything is follow-up, follow-up, follow-up. If you ever get a chance to pull your reactivation patients that are unscheduled, your recare recall list, it's shocking how many patients are actually on this list. We feel like a patient walks out and reschedules all the time. I can promise you it doesn't happen. Usually when we put dental intel on a practice, it's about 50% of the patients, active patients, have no next appointment, zero next appointment, if you can believe that. The other couple ways to boost your hygiene department is measure. If you're not measuring, if you don't know KPIs, it is something we help. You can look them up. If you don't know what this industry standards are, that's number one miss. And if you don't know what your team's KPIs are, that's another miss. That's your key practice indicators. So right here, I just showed I'll just throw a couple out. Treatment acceptance for you all are different than a hygienist. Hygienist average 60 to 75. Strong 80 to 90% of my diagnosis should be scheduled. I'm talking about the foundation of their entire mouth. It's a less expensive procedure and it's covered at 80 instead of 50. If I can't slam dunk those treatment plans, something's wrong. Perio should be about 30 to 35% of your practice. Gingivitis therapy should be about 15 to 20. I know I'm talking fast. Reappointment rate, I like to see in the 90s. If I have my way, it's 94%. Fluoride, adult fluoride, about 80%. We can talk about where you live and how that differs. It used to be a hygienist should produce 3 times their wage. It varies whether you're a heavy PPO practice, you're a fee for service practice, but I'm going to say average, they should be doing about 180 to 250 an hour. High performing are about 300. I am recording this too. Did I? Oh, shoot, I didn't. Okay.
I did.
Okay, good. I was going to say we could even take notes on it. A hygienist should produce about 12 to 1800 a day. Fee for service or high performing about 2. If you're all insurance, your hygienist is probably not going to get to 2000 a day. Okay. But 12 to 18 is doable. That is like, I'm a stellar diagnoser. Okay. Don't go back and kick your hygienist in the shin if you're at like 900. I would say most of the practices I work in, when I get to them, they're like 700 to 900. Some of them pop up in the 1,000. That's pretty normal without training. So don't, get mad at them, get them training. So I think this my last 2 points are cancellation and no-show. If it's running amok of your system, you need a better protocol. There's got to be a system in place for cancellation and no-show. As a hygienist, I can't control it. What it will do is destroy my schedule, and it definitely won't boost your hygiene department or chair. So if you have a cancellation and no-show problem, and you're seeing it especially a lot in the hygiene department, a couple of things could be happening. It could be our confirmation and no-show process, our confirmation and reminder process. It could be that we're too lenient on the whole thing. It could be our hygienist. There could be an issue. There could be a non-trust issue. Don't go there first, but it could be, why aren't patients rescheduling with her? So just or him, just think about that. And my very last thing is, if you do have a cancellation and no-show problem, first get your protocols and policies in place like crazy, but track it like nobody's business. Most time at the time when I get in dental intel, cancellations are kind of tracked. No-shows are always 0, 0, 0, 0. So what I know of practice management software, if you're leaving a patient in a column and then you're trying to call them, and then when they finally answer and you just move them, it's not tracked. You have to break the appointment, and each software is a little bit different on how you have to do that. The reason it's important is because if Paula is notorious for canceling last minute, there's 2 things I want to do. Her confirmations are getting a lot of love. She's going to get a lot of love a week out, 3 days out. Like, I am going to make sure that girl gets lots of calls, and not automations. She's going to get like a personal phone call from the office manager, maybe even you as a doctor. Okay. Because she's going to do this. We know she's going to do this because we've been tracking it. Or I'm going to create a ghost column, and I'm going to go ahead and put a patient in Paula's slot right beside her, because she's going to cancel on me last minute. I haven't heard from her. She hasn't responded to any of my stuff. I'm going to go ahead and schedule someone. I'm going to leave her a message. There's a way to do this. Don't just put somebody in there. I'm going to leave a message 3 days out. Hey, if I haven't heard from you by tomorrow, I'm going to go ahead and fill that slot. And guess what? I'm going to fill it. But I'm going to leave her name there, because guess what? She's probably going to show up, and now we got to be prepared for that. So there's a lot that goes into a ghost column. Please do not go. What do they say on those shows where they do dangerous stuff? Like, don't try this on your own. It can result in really bad things. Any of this stuff I just told you, before you go back and implement it, before you sit down with your hygiene team, please just do some research, because it's not that easy to just throw a 43, 46 on the schedule. It's not that easy to just create a ghost column. There's a lot of thought that goes into it, and you have to create a system, and your entire team has to be on the same page, or it's going to fail you. And that's what I want to make sure you know before you do that. This is how you contact me. Obviously, you all know Michael. I'm going to stop doing this so I can actually see somebody. Is that cool?
Yeah. We have time. I just thought maybe you all could bring up some situations that you see in the office. With your hygienist, associate, or owner.
I know I had lots of questions in there, but when I got your text, I started panicking, and I wanted to get through how to boost the department.
And maybe we could spitball some of that on the fly. What are some of the biggest things you all see, and the myths of some of this stuff that you heard?
So when we diagnose SRP, insurance is denied, and patient does not want to do that. Do you move forward with a Prophy, or do you still push for SRP?
So you're saying you feel the patient is completely educated, they understand the consequences of losing their teeth, and they still are just like, I refuse to move forward.
And then do you provide regular Prophy, or do you just don't treat them because they not okay with it?
So I have a multiple approach. The first thing I'm going to do is document like crazy. Document. I'm going to have them sign a refusal form, and I'm going to get them a referral form to a periodontist. All that's going to happen. Then I'm going to say, I'm happy to do a cosmetic cleaning on you today. Just know that it's cosmetic. I'm cleaning the stain and tartar off above the gums. You're still at risk of losing your teeth. And I am going to give you a referral to a periodontist because I feel like if you don't want to be treated here, you need to go there because at some point you're going to lose your teeth. But we will do your cosmetic cleaning today. The reason I do that is I look at it as, and sorry if anybody's going through this, cancer is such a sensitive subject. I hate using this as an example, but it's the best example. There are a lot of cancer patients that choose not to move forward with treatment. They get that choice, right? If I don't want to do radiation or chemo, I don't have to. That doesn't mean that a doctor is still not going to see me. It means I've refused that route of treatment. I've chose something alternative, which is either nothing or maybe something holistic. So I feel like gum disease, as detrimental as it is not as severe as that. So for me, as long as I am protected from the board, I have documented, I have had them sign a refusal form, I have referred them out, and I have let them know this is a cosmetic cleaning. You can even create a thing for that consent form for, hey, we're doing a cosmetic cleaning. And I feel comfortable. I do feel comfortable moving forward.
I'll say this, that like, that's why she said it the way she said in the beginning is okay, you feel this way, you feel this way. After you go through that entire process, the patient really is taking ownership, and it prevents them from doing that to themselves. Does that make sense? And so it's almost like being so extreme that you're making a point that they're choosing not to be healthy.
Unfortunately, there's no black and white out there about can you treat a patient or not, which is why this is a huge question that always comes up. The only way you really get in trouble from a board is lack of documentation, lack of a perio charting, lack of a consent form. And doctors will say to me all the time, well, a consent form or refusal form does nothing. Absolutely, if that's the only thing you have. If you try to just sign a refusal form and you're lacking in so many other ways, you are going to get in trouble. But at the end of the day, no matter what I say, it's your license and you have to feel comfortable the way if you want to kick someone out of your practice or however you want to handle it is ultimately your decision. But that's my opinion. That's what I've done in the past. And I feel as a grown adult, if I make an educated decision that I'm willing to move forward with a cosmetic cleaning and I don't want it and I completely understand, then it's my health. It's my choice. Okay.
And the insurance denied it because
Wait, I missed that. Insurance denied it. Did they send it a predetermination or something?
Sometimes the insurance doesn't accept the treatment.
Yeah, the question was,
But they can't have both. So did they send a predetermination and they said they couldn't have it, or they already did it? Because I've already done it and then they don't refuse to pay it, that's a totally different conversation. Is that what you meant, Doc? Like you did the periotherapy and insurance refused to pay?
She said initial estimate.
Did you hear that?
Just the initial SRP, sometimes insurance deny it.
Okay, so you did the treatment and insurance denied it.
before.
So you did a predetermination. You sent it in to see if it would. Oh, okay. Yeah, so that's just educating the patient on, what you're seeing and what your professional opinion is. Insurance doesn't, unfortunately, on the other side of insurance, isn't always a dentist or a dentist that's been in clinical in a really, really long time. So what I'm just going to tell you this. I am the queen of getting insurance to pay for things. Whenever we have a billing department, whenever they get denied, Stefani sends them my way, and then I fight them with smarter words than they have. So I think if you are on the verge of, that's another way Chrissy asked earlier about AI. It's another way Pearl AI really helps is because, or one of those companies is because it shows, it helps back it up when with the bone loss and different things. There's several of them out there that back it up with the bone loss, and they kind of let you know, hey, here are the things. And usually if you have that evidence, they'll also be more inclined to pay. But I think if you can show them where there is horizontal or vertical bone loss, you can point it out. You take vertical bite wings instead of horizontal bite wings, and you really throw your clinical diagnosis at them. Because when you sent it in, or whoever sent it in, it may not have done it strong enough the first time. So it's hard to say without seeing Wyatt, but I do think if you do the bare minimum on a questionable, you're going to get denied. So I wouldn't just send in a periocharting and bite wings. I would back it up with a lot of clinical evidence when you do that. But once it's already denied, I can understand why the patient's fearful. However, your clinical diagnosis is much stronger than an insurance company, and you just have to prepare them for the payment. Yes, Michael.
Do you guys feel that your front office teams are helping the hygienists be productive? Have you thought of it that way instead of blaming the hygienist?
I mean, in terms of scheduling.
Well, just scheduling, but preparing them, but
Right. Pre-approving.
the insurance verification, getting all the information on the 4,000s, just really setting them up to sell.
I agree, Michael. It was one of my slides, and one of the things I wanted to hit on was it's unfortunate that everybody's on an island on their own. You know, you've got your front office team, you got your dental assistants, you have your hygienist, and it can get very cliquey. What they don't understand is it's a team, right? It's a team and it's a patient. And we want to throw everything we can at that patient experience. And we want to throw everything we can at all the team members. It's your patient's 1 hour in your practice. So what Michael's saying is, it's not me just diagnosing and treating. My front office has to be fully prepared with all the breakdowns so that I can do a last minute presentation and treatment. And then they have to be fully prepared. And if I didn't provide enough clinical notes, they have to be fully prepared to fight that for you, the practice, and me, because there just wasn't enough evidence. Not, oh, it just got denied. So it is a real, guys, it's a business. It's a crazy business. We treat it very lightly and very lackadaisical and very like, oh, because we're so used to like, we diagnose, insurance pays. That was the way it was for years. But insurance now is wanting AI. They're wanting more, evidence. There's just so much that goes into it. And I don't know if it's because they're getting cheaper or people are getting more greedy and they're seeing that. I think it's probably a combo. Yes, Michael, sorry.
I just see a lot of, I hear the calls. I hear the bitching. You know, my hygienist, I'm just going to do them at 7. They're $85 an hour. I hear all those. But then I also know the front office people, the quality of the front isn't very great either. And so I'm thinking of this like dance that Paula went through with the handoffs, the insurance verification, the scheduling, and the understanding of all the codes. And, you know, like if your front office person isn't like a badass, then how is your hygienist supposed to sell it? So it's kind of both. And if one's not great, then the other's not. They're great, both great, they're probably going to get great results. You know what I mean? I think it's important to look at both. So anything else, guys, as we wrap up, and then we can just kind of hang out for the last 15 minutes.
Yeah, few patients, Paula was telling, spending 90 minutes, like 30 minutes in the dental chair and then 60 minutes with the hygienist, right? And diagnosing and then treatment planning wise, different doctors costs. How many people do you recommend seeing the patient before, before patient dismissal? Not overwhelming the patient.
What was the last question? How many patients do you see?
How many people from the office should see the patient? Explaining.
How many touches
How many-
different
How many
people?
handoffs should there be to get the maximum case acceptance? So,
Yeah.
what's the count, handoffs?
Yeah, I mean, I just think as many that touch them. I don't think you need a certain number of touches. I just think every touch has to be consistent and it has to have the same language and you have to pass the power to the next person. And I think the patient, it's important. If you have those little things you need to say behind the patient's back, find a different way to do it. But you shouldn't walk into the dentist office and say, Paula's concerned about the upper right. She has some periodontal disease. Come back in, and now you go straight into my mouth and you say that without the hygienist and the doctor talking. Usually what I'll do is I'll say, hey, Mrs. Patient, hey, Christy, Doc and I are going to talk over you for a few minutes. I promise we're going to explain everything. We get into the dental lingo, but we are going to tell you, and we'll do it on purpose so she can hear it. And we'll do it in some layman's terms after we do it. Sit the patient up. You explain to the patient. Even though I just heard you as a hygienist explain to the patient, you're going to look right at me again. And you're going to say, this is what Christy needs, when, where, how, and why. And I'm going to say, okay, I'll get Christy scheduled. I'm going to take Christy up front and I'm going to explain the same thing to the front office. Rule of thumb in marketing is like people have to hear things like 7 times. That's a little overkill in the dental office for sure, but it's not false. If you just look at Christy and you tell her and I walk her up front and briefly tell, or I write it on a routing slip, she's going to have no idea what just happened. So if I've already prepped her as a hygienist, you come in and we talk over her, then you sit her up and tell her, then you tell me exactly what to do. Then I take her up front and tell the front office what to do. We have already made like 5 touches right there. You don't necessarily have to have the dental assistant involved. You don't need to keep touching her. But if the dental assistant's involved, you want that same, you're going to do the same thing with the dental assistant. Then the dental assistant is going to come tell me as a hygienist that in front of the patient, and then I'm going to tell the front office. So there's going to be a few more touches.
We see in really successful offices when we do our office observation day. I'll just be sitting at the front and Paula will be in the back, and after we're done and watching, we come together, and it's like successful offices still don't even have the handoffs down. I mean, the hygienist is like, okay, you got her good. I gotta go. It's like,
Yeah, it's usually the front office is on the phone and the patient's now standing waiting on the front office to get the phone, or the patient's wandering around the practice not even knowing where to actually go to the front office, or there's all kinds of crazy shit happening and you're like, what is happening?
just wandering along.
Your question too could be a good one when you're talking about a new patient, like
Yeah.
how many people do you want them to touch, or how many people do you want to touch that new patient?
Right.
Maybe not in handoff form, but just, and I would think you'd want pretty much everyone. You want to connect them to the office, right?
Yeah, I think, the dental, no offense to dental assistants, but it can be skipped sometimes if there's no reason. Now, listen, in a perfect world, sure, they pop their head in and say, hi, welcome to the practice. That would be like next level shit right there. But if it's just a matter of treatment, typically, if it's in my chair, I'm going to go get them as the hygienist. It's going to be me, doctor, in front. You don't necessarily need to involve the dental assistant, but I love Christy's concept there. Like, it's like If we're Disneyland and everybody's coming in and saying, hey, Chrissy, welcome. Hey, I'm the dental assistant. I'll probably be, hopefully not, but maybe seeing you in the future if you have some treatment, you know, stuff like that. I mean, yeah, that's like, we're taking that all the way to the top. But I would say that the most important thing is less about the people who touch and more about the consistency of the touch.
Okay, so last question. If you guys could, if you wanted to say something to a hygienist and you don't know how to say it, what would that be? Have Paula help you with that?
And I'm the toughest hygienist out there. So if you say something to me, I'll let you know. It'll
So
offend me.
you all have these hygienist lives. They probably frustrate you, whatever. Or maybe not, I don't know. But like if you wanted to say something to a hygienist, what would that be? And then maybe Paula can
I'll just tell her to communicate properly with dentists.
how to what?
Communicate.
How to approach her for better communication?
Yeah.
With the dentist.
With you.
Yeah.
In like clinical or management or? Okay, did you catch that?
How to have her communicate better?
Clinically to the dentist.
Okay, I have a question and then I'll answer that. One thing that I skipped that I want to make sure that I go back to really quickly is in that 2020, I like breezed past it. 20 minutes of scaling. Remember when I did the 2020? The other thing is getting the doctor earlier in on an exam. If you're coming in at the very end of my exam and I have 5 minutes, you're doing your jibber jabber, and then I got to turn the room over and now I'm running behind, I'm probably not doing anything for you. At this point, we've lost our rapport. If you can come in somewhere between 15 to 20 minutes after, if I have x-rays, 20 is better. If I have no x-rays, 10, 15 minutes. Between that and 15 till, I always say 20 till, but 15 till, you and I are going to have a way better rapport, because even if you take 5 or 10 minutes, I'm going to be in a better mood because I know I have time to make up. If you're coming in the last few minutes, my eyes are already rolling because I've been waiting on you. I don't even like you right now. Okay. Because I've had to sit and I know you're getting me behind. We're not doing well already. But if everything else is perfect, I mean, for me, it's about the why. This is a big question because I don't know what all is happening or what's going wrong, but just like off the tongue, essentially, I would just say, I would look at your enrollment, both perio and dental, and I would approach it in a we thing. I would say, what I want to do is improve case acceptance, both on my side and hygiene. And the way we do that is have better communication and rapport. You can even use this tonight. Hey, I went to a webinar or a study club, and what I have found is patients want to hear that communication in a clear, consistent manner. And we do that a little bit over them and a little bit with them. But I always like to say to the patient, hey, we're going to talk over you for a few minutes because I don't want them to feel left out. And you have to master that as well. But let her know you're in it with them. You both need to improve. What can I do better? Because you may mumble. Like when people mumble, I'm just sort of like, okay, just get out of my room, So there's some things that you might be able to improve on too. And I think if you approach them as a professional colleague and team member and employee, and you want to get better together, that will go a lot further than coming in and saying, I can't hear you. I don't think you do a good job at this. There's always this sandwiching of positive, what can we improve on, and another positive. The other are you an owner, doc?
No.
Okay. So this is a little bit more sensitive because you're not the boss of them. Okay. Yeah. Then I would more approach it like that. When you become an owner, it's a little bit different because you want to do those touch bases and how they can improve in your business. But in this aspect, I would just say, listen, you help me make money, because every time I do an exam, it's a marketing opportunity. It's an enrollment opportunity. Don't say marketing opportunity to her, but it's an opportunity for me. Now, obviously I want to diagnose what's there and not diagnose what's not there, but together we make this exam. It's not just me doing the exam. Together we make this exam positive and what am I trying to say? Whatever. So I need you to help me also. And so we call that co-diagnosing. So anything you find, I won't put you down. I won't squash it if it's not. So if I diagnose something, if I say to you, hey, number 4 looks like something's there, you need to say to me, I see what you're talking about, Paula, but let's go ahead and mark that. We'll check it next time, not a watch. We'll check it next time. And I'm seeing this, this, and this. So never make me look stupid in front of a patient or else you're going to lose me forever. But I think it's just you sitting down and saying, I need help. I want to do more. I feel like my diagnosis and enrollment can be better. And I'd love for your assistance in that. That's probably what I would do. Does that help? Okay.
Thank you. Good question.
I
One more
talked.
before we shut that. Yeah.
Do you recommend any adjunctive hygiene services? Like sometimes they do laser, you were mentioning about pyros, so recommend like any other service on top
All of them. Yes.
This follows about the 10 p.m.
So if I don't know, I'll say it quick. If I don't have a laser, I'm going to probably use irrigation and some kind of antibiotic or perio tray or something. If I have I'm a laser hygienist. I've been using lasers for 29 years. If I have a laser, I don't need anything else. And I will charge for the laser, and I have specific ways I do that. But if I don't, now I love MI paste and fluoride and other things like that. But I'm talking like when it comes to irrigation or antibiotics, those are things I'm going to use if I don't have a laser. So absolutely, I agree with adjunctive therapy. I agree with some product in the practice. I like to have product too, because I'm really big on water picks and electric toothbrushes. So I'm not like going crazy. I'm not trying to make bucks off of it. I just want it there. I'm also big on certain antimicrobial rinses. I'm big on Oracare. That's like my go-to. If I'm not going to use Oracare, I'm more of a closest person, but I want to just be careful. There's some stuff on Paradox and irrigation. So just be careful there. I'm a hygienist, so I'm a little bit more nerdy than most people. Some people irrigate with chlorhexidine. I'm a little bit like shy away from that. I do think there's a place for chlorhexidine 100%, but not in the irrigation. So yes, the answer is 100% I believe in it. 100% I want it there, and 100% I want everything thrown at my patient possible to get them in a healthy state. And then if we want to back off some of that, we certainly can. But at first, I'm going to hit them with everything so that I can get them to a place where I feel like their oral health care is protects their body and they're not causing other issues. Yes, Michael.
Are sealants considered adjunctive? Sealants?
Sealants they're really just a service. I wouldn't necessarily consider them adjunctive, but I do love sealants. And I would say that if you're a sealant believer and you love sealant, have a tray ready in your hygiene room. We're the kind of people, we're not going to get up and go find things. We need our own. We need our own laser. We need our own sealant tray. We need our own, kind of everything, or else we're going to say we don't have time. So if you are going to do a sealant, obviously have a protocol around that. You don't want me putting a sealant on a tooth that you don't want to have a sealant. But once you've done that exam, if you believe in sealants, I love sealants, bust them out. They're a great money producer. And on a virgin tooth, why not? Or at least give the patient the choice. Is that, were you talking more sealant stock or more like laser and yeah? I have a laser in my closet. I use my laser a couple times.
She's laser.
Just so you guys know how nerdy I am, I helped BioLaser design and develop the Epic H. So that's what I have in my closet.
And it helps jaw pain.
And it helps hepatic functions and all kinds of things. So yes, I love it. Anything else?
guys could always reach out to Paula. She's an extension of me, and yeah. No, thank you, Paula.
Was it just for future, because I'm sure I'll be back. Was it too? I mean, I got rushed by Michael, but was it too deck heavy? Too much information? It seems like you like this more back and forth, like, or was it just enough? Like, give me a little feedback on that.
I think it's right amount of information.
Okay.
It's really good, yeah.
Okay. Awesome.
Sorry for all the topic, clinical management, everything.
Okay. Because we are nerds at heart, right? We're clinical. We like to nerd out a little bit. Michael's not a nerd like us, so we like a little bit of that clinical stuff. So okay, cool. All right. Well, have a good evening.
Thank you.
And hopefully I'll see you in person sooner than later. Okay. Okay. Bye.